do that. Okay, so we are recording now. Sorry about my camera is not working, so you just have to bear with my picture. Right, so we are in week 9 and we are talking about written communication report writing. And this is probably the first week of report writing, and week 10 is about report writing as well, with a bit more things about ethics and code of conduct kind of thing, rather than writing the radiology reports. So yeah, so writing the radiology report is basically your assessment as well. And if you look at the reading material, the first thing under that is examples of report writing. And that's a PDF file with 4 reports, okay? Now, all of these reports are fine. They are not wrong in any way, okay? It's the same patient, 38-year-old woman, positive pregnancy test, 9 weeks. Ultrasound was done 4 weeks ago. And at that time, fetus was not identified. And she's having PV spotting and lower abdominal pain for 2 days. And they are thinking that it might be ectopic. Why are they thinking it's ectopic? One thing is, obviously, they're having PV spotting, pregnancy test is positive, but the previous ultrasound did not show an intrauterine gestation, and obviously didn't show the extrauterine as well. However, look, 9 weeks gestation, if you deduct 4 weeks out of that, the last ultrasound was done at 5 weeks. 5 weeks is borderline where you start seeing the gestational sac through transabdominal ultrasound. And the patient at that time and on this time as well refused TV scan. Lots of patients do that. Obviously, you cannot force them. You can only have you can only recommend that. So in this report, you have only got the patient's name, Miss Dorsday. That's it. Like I said before, you need at least 3 identifiers. So identifiers are missing here. This can be a wrong patient. We are not sure if it is exactly the patient which we are doing, because there is just the name there. The clinical notes are basically the radiologist or the sonographer or whoever wrote the report just copied and pasted whatever was on the referral. They did not go any beyond that and did scan. The referrer, probably a GP, specifically requested transvaginal. And in technique, it said transabdominal ultrasound of what? It doesn't say. And patient refused transvaginal ultrasound. It doesn't elaborate on that. That although the GP asked for transvaginal, we should give a reason why the patient has refused transvaginal ultrasound. You can simply say that patient did not give consent to transvaginal ultrasound. That is good enough reason. But refused is a little bit, this term is rather implicating to the patient, that patient refused it. So it's not a good word to use. Patient did not give consent is a more polite way of saying the same thing, rather than saying refused transvaginal ultrasound. Comparative examination, they said previous ultrasound was performed 4 weeks ago. Now, what was the findings at that? Yes, we know that it was done 4 weeks ago. The clinical notes say that. So what's the added information there? what was on the previous ultrasound, what are you comparing it with? Uterus, mild thickening of the endometrial echo. Now, it is wrong in so many ways. One thing is mild. What do you mean by mild? 6 millimeter, 10 millimeter, 20 millimeter, or 1 millimeter? It's a relative term. It's a superlative. It's a qualifier of thickening. And it can have different meaning for different people. If I am looking for, let's say, a pregnancy, I would expect ultrasound thickening of the endometrial stripe to be maybe 10 to 12 millimeter. Mild thickening is it 10 to 12 or is it 15, 16 millimeter? And then 15 millimeter for somebody can be mild, for another person it can be moderate, for another person it can be severely thickened. So don't use qualifiers. Mild, severe, slightly, these are the words which are best avoided because they're ambiguous and can mean different things to different people. Thickening of the endometrial echo. Now, what is an echo? Endometrial echo doesn't mean anything. Are we talking about endometrial stripe or endometrial echogenicity, or we are talking about something inside the endometrium which is echogenic? That's not an anatomy that is pointing it out. So I would say the endometrial stripe is 6 millimeter in thickness. Now it is up to the, and then in brackets I can put in normal 4 to 8 millimeter. So the reader would know, is it mild, is it severe, is it whatever, it is. Ovaries, right, normal, left, physiological corpus luteum of pregnancy. Okay, I can sort of live with that, but do you really, it is an interpretation of a finding, the corpus luteum. It is not a finding. So you have not described what you have seen. You have made a judgment that this, whatever I've seen there, is a corpus luteum. How big is it? Is it resolving? Is it advancing? What is its echogenicity like? What is its outline? Is it really corpus luteum, or is it an ectopic pregnancy in there? Adnixae, no mass or other abnormality. Okay, it's a passing sort of statement, but I can sort of live with that. Kidneys normal. You have to put in the negatives as well. So I would mention that there is no abnormality seen rather than saying kidneys are normal. Other finding, there was a small normal amount of free intraperitoneal fluid. Where was it? Intraperitoneal, which means that it is inside the peritoneal folds, and posteriorly the pouch of Douglas is intraperitoneal. But an ectopic can be fluid, can be intraperitoneal, it can be extraperitoneal as well. And how much was it? Small, normal, how much? Conclusion, findings are compatible with either a very early intrauterine pregnancy, less than 7 weeks, or an ectopic pregnancy, or a complete abortion. Now, this report does not help the referrer at all, because he is already suspecting that this probably it is an intrauterine or an ectopic or a miscarriage. Okay, the word abortion is also not a good word to use nowadays. Maybe 10 years back, people said complete abortion and incomplete abortion, but at the moment, we say miscarriage. It can be or TOP, termination of pregnancy. Termination of pregnancy is a willful abortion when you go to somebody and they terminate your pregnancy either medically or by vacuum or by curettage or whatever. Or it can be a spontaneous termination, or miscarriage, which basically means that it happened by itself. Abortion word is no longer used in a positive way. And then Dr. Polenka, who is he? Is he a radiologist? Is he a PhD? Is he, I don't know who he is, and the date after that. So report 1, if it goes back, it, number 1, does not help the referrer at all. Second thing, it does not give any new information whatsoever. Third thing, it does not give the reader any sense of what has been seen and what has been looked at. If you say uterus is mild thickening, what is its clinical significance? And then pregnancy test has been positive for 9 weeks, and here it is saying it is an early intrauterine pregnancy. Now these two don't go right. So you can say here that dates of this ultrasound scan do not correspond with the known age of pregnancy. Known age is when the positive pregnancy test was positive. It should be an LNP because pregnancy test could have been done at 5 weeks of gestation or 10 weeks of gestation. Some people miss a period, then they wait that, okay, maybe, periods are going up and down. They wait another month. They don't have 2 consecutive ones. They get a pregnancy test done. Especially multipara women who've got small kids already, or with the irregular cycle, they are not really concerned if they are pregnant or not, compared to a primary gravida or somebody who's actually working towards having a pregnancy. So yeah, so if you write your report like report 1, it does not tick all the boxes of a good report. So that probably would not get you a pass mark because there are more questions on that report than the information provided. Let's talk about report 2. Patient name and date of birth, but still there are no 3 identification parameters as required by law. So it could be the same patient and the same date of birth, although much unusual, but still you can have that. You don't have the 3rd requirement. Here the clinical notes are again exactly the same as the referrer mentioned. There is no added information that the sonographer asks the patient or the radiologist asks the patient. The findings are a bit more elaborate. A transabdominal ultrasound was performed even though transvaginal scanning was requested, as the patient refused transvaginal scanning. Again, the word refuse and no reason is given. Explanation of the procedure to her was difficult due to poor understanding of English, and interpreter was not available at the time of scanning. So perhaps this was the reason why she refused a transvaginal scan. but maybe it's the ethnic or racial or religious um, um, reason behind that. So what do the, what does this information help the GP? Basically, you could add that ultrasound may be repeated urgently with an interpreter or with a proper explanation of the procedure to the patient. But again, they can still not give consent. The uterus was anteverted and normal in size. Normal in size, you have to give dimensions, and showed an endometrial echo. Again, endometrial echo is not the correct anatomical term. Mildly increased in thickness. It doesn't mention what it means. No gestational sac was seen in the uterus. So at least this report has ruled out an intrauterine gestational sac. Right ovary contained a 2.3 centimeter cyst, cystic structure demonstrating ring of fire sign. On Doppler examination, it is explaining that corpus luteum a little bit better, although in the previous report, right was normal and left had the corpus luteum. Here the right ovary is, and it doesn't talk about the left ovary at all. No adnexal masses were seen. Whenever you say no, always use a singular. No adnexal mass was seen, rather than no adnexal masses were seen. Because if you did not see any mass, okay? So it's just the way you talk about it, rather than it's just a use of language, how you describe things. Some free fluid was seen in the pouch of Douglas. At least the previous report said that there was a small amount of intraperitoneal fluid. Here it says it is in pouch of Douglas. I think I should share this with you so that you can read along with me. Can you see the reports I have? Okay, all right. So we are talking about these things. Okay. And here in this report, at least it has said that the previous ultrasound, which was also transabdominal, performed 4 weeks ago, showed no evidence of intrauterine pregnancy. So without going back and then looking at the report and then the reader comparing it, you have compared it, and at that time there was no intrauterine pregnancy seen as well. The conclusions are important here. No intrauterine pregnancy is seen. Ultrasound finding might be consistent with ectopic pregnancy or spontaneous abortion. A normal intrauterine pregnancy is somewhat less likely if patient had a positive pregnancy test 9 weeks ago. So you are rationalizing your findings. This is helpful for the referral. Okay, so, and it is giving you recommendation as well. Daily beta HCG estimation might be helpful in determining which of the 3 possibilities is more likely. So Mr. Paul Enka, who is suddenly become a fellow of the Royal Australian New Zealand College of Radiology, so we know that he is a qualified radiologist, is giving his opinion. Daily HCG, probably not, maybe every second day, or daily is fine as well. But it leaves it to the referrer to do this and then read the report again and think of whatever there is. So this report, if you write a report like this, may If there are no grammatical mistakes, there are a few sort of things in there, but it may just get you over the line of 50% pass mark. It does help the referrer, but it lacks a lot of insight, and it lacks a lot of explanation and of things. Third report is probably a lot better. You have three identifiers. You have the name, age, or date of birth, and the MRN number. So we have three identifiers. We tick the boxes. We have shown that when it was done and when it was reported. So we have the chronology of this, but the clinical notes are exactly the same as what the referrer has said. The findings are the same. I think explanation of procedure was difficult. Explanation of the procedure due to poor understanding of English, and the interpreter was not available. So same thing. Maybe elaborate a little bit more and say that this was the reason why we didn't do TV ultrasound. There is additional information there as well. The patient is gravida 3 para 2, which means that she has 2 live babies from 2 previous pregnancies, and this is the 3rd pregnancy. And currently not on any contraception. So, that is added information. So just a little bit of added information, but it doesn't really say a lot about what's happening with the patient. Uterus was anteverted and normal in size. It gives the measurements, but it doesn't give the normal measurements along with that. So when the report says that these are normal in size and then in brackets given values, we have to believe the person, and we have to look up these normal values ourselves. Showed an homogeneous echogenic endometrial echo, again endometrial echo, mildly increased. So again, echo is the wrong word, mildly is the wrong word, in thickness, and it says 7 millimeter. What would you expect from a pregnant uterus? 7 millimeter is mildly increased in thickness, or is it normal in thickness for a 9-week gestation? No gestation sac was seen in the uterus. Right ovary, it has given the volume. It tells you about the finding on Doppler. This is diagnostic of a normal corpus luteum of pregnancy. So it has given the interpretation that whatever you're seeing is there. And left ovary was normal and no adnexal mass were seen. Again, using plural there. And the previous report did not mention the left ovary. Here it has mentioned left ovary. Some free serous fluid. Okay, it has added the word serous there, which means it does not have any debris or any floaters, and it is a clear anechoic fluid. Physiological an amount and anechoic. When you're saying serous, you mean anechoic. So you're doubling what you are saying. Was seen in the pouch of Douglas. Kidneys were normal with no hydronephrosis. I would mention their size as well. Conclusions, a bit more elaborate. The observed combination of findings could be seen with an early normal intrauterine pregnancy, an ectopic pregnancy, or a spontaneous abortion. Okay. After that, it says that beta HCG levels would help to distinguish between these possibilities. How to do that? If it is above 6,500 and we don't see a gestational sag in the uterus on TA, then the likelihood of ectopic pregnancy is more than 90%. So it has directly given a fact which helps the referrer. And if it is less than 65,500, then the current ultrasound findings are still compatible with an early intrauterine gestation and this and this. Close clinical follow-up is recommended until a definitive diagnosis is reached, because ectopic pregnancy has not been excluded with a high degree of confidence at this stage. So it is telling the referrer to do something about it. Don't take it lightly. We cannot exclude the ectopic. You have to follow it up. If, see how the beta HCG is going and how it is. So this report would definitely give you a pass and maybe even a credit, or, if I'm, smoking something suspicious, maybe a distinction, but maybe not. But definitely pass or a credit will go there. Number 4. A little bit of marketing going on there. Dear Dr. Bhatt, thank you for referring Ms. Day for ultrasound of the pelvis. It is a polite way of personalizing your report. When it goes back to the referrer, he's happy and he says, oh, okay, that radiologist is addressing me, and whatever is following is directed towards me. He is directly giving me information. So very small little addition goes a long way in building the confidence of the referrer in you, even before they would start reading the report. Patient name, date of birth, MRN is fine, 3, but it has also added an address there. Super fine. Examination date and reporting date is there. It has copied what was written, 38-year-old woman, positive pregnancy test, ultrasound 4 weeks ago, PV spotting in lower abdomen, this, up to here. But then it adds something. The sonographer reports that the patient had 1 episode of slight PV spotting 6 days ago with cramping pain. Everything is now completely in a different context, right? Here in this report, it is something like, oh, she's having huge, big bleedings, which is going on and on and on, and we don't know what's happening, and the patient is going to die if we don't do anything straight away. Whereas in reality, she only had a PV spotting 2 days back, 6 days back. There was a bit of cramping pain. There has been no pain or spotting after that. There is a slight, I would not use the word slight, tenderness is tenderness. Tenderness is in right iliac fossa is noted. Patient is GIS3P2 and currently not on any contraception. So you see how important it is to add information to whatever is provided by the GP or the referrer or whoever, because now when when this report goes back to the GP, he would say that, well, okay, yeah, they interviewed the patient, they took care of the patient, the duty of care, sorry about that, the duty of care was there. This is a good radiology practice that they are taking a patient seriously and asking the patient in making a decision. Here also, same thing, technique, transabdominal ultrasound was performed according to the department protocol. So we know that a certain protocol was followed. If we want to know, we can always come back and ask them, excuse me, what is your departmental protocol? If it goes to a court, okay, the previous one doesn't mention that. Transabdominal ultrasound was performed. Where, when, how, when it goes to court and the lawyer or the judge asks you, What do you mean by transabdominal ultrasound? You don't have an answer. But here you have department protocol, and if they want, they can have access to the protocol, and it mentions everything in there, and you followed that. Even though a transvaginal ultrasound was requested, as the patient refused transvaginal scanning, again, I would not use the term refuse. Explanation of the procedure to her were difficult due to poor English, interpretation were available, and in addition, patient also requested a female sonographer, which was arranged. She was accompanied by her husband during the scan. Bladder was adequately full for the examination. So we have elaborated why and what were the circumstances under which that ultrasound was performed. And it gives you, gives the reader an impression that all possible care was given to the patient, and what were the circumstances in which the scan was done, so that the reader can have confidence in your findings. Comparison, transabdominal pelvic ultrasound 4 weeks ago at another center. Previous images and reports were available for comparison. No current beta HCG values are available. According to the patient's husband, she had positive urine pregnancy test 9 weeks ago. Okay, but we don't know. It's according to the patient. So up till now, what we have shown is, number one, duty of care. Number two, and there is, if you look at your marking rubric, there is marks for duty of care and performing of the adequate examination in the marking rubric. So you have to show that there was adequate care provided to the patient in your report. It has given, number one, what is actually happening with the patient at the moment. Number two, it gives you an outline of how this scan was done and what were the difficulties and what would then be the limitations. I might probably add another sentence here that due to poor understanding of English and unable to follow instructions, the ultrasound examination was difficult to perform, however, was clinically adequate. Right? If it was not clinically adequate, I wouldn't write another word in the report. I would just say the ultrasound performed was inadequate clinically for interpretation, send the patient back again. I'm not going to report on an inadequate examination. Findings, uterus, and it gives the size in largest dimensions. Myometrium is homogeneous, no focal lesion. Small, healed, old C-section scar is noted in the anterior lower section. Fine, you have given more information about the uterus itself. Endometrial echo, I would use the word stripe rather than echo, appears homogeneously echogenic, 11 millimeter in thickness, which appears to be slightly thickened. Again, I would not use the word slightly here. No gestational sac or focal lesion was seen. Kidneys, both kidneys appear normal in size, shape, and outline with no hydronephrosis noted. I would mention bipolar length of the kidneys also, and corticomedullary junction distinction. Pouch of Douglas, a small physiological amount, probably not a good word, estimated at 5 ml of serous free fluid containing no internal echo noted. So this is not blood. Okay, so we can say that probably this is just a normal amount of fluid, about 5 ml, which is normal. I would probably mention in the brackets normal less than 5 ml of fluid, or 7, I think. I don't exactly remember what is the normal physiological amount. At Nexa, no focal mass of fluid collection seen on either side, no abnormal vascularity seen. So all the signs of ectopic I have said there's no mass, there's no fluid, there is no abnormal vascularity or the gestational sac or whatnot. So I have excluded any ectopic stuff there. Right ovary, it's measurement. There is a solitary 2.3 millimeter cystic structure, ring of fire on Doppler. Diagnostic of corpus luteum noted, no other mass, no free fluid around ovary. Same thing about left. It contains 4 discrete follicles, the largest measuring 6 millimeter. Leave it to them. These are just normal follicles. And when it says discrete follicles, you mean that these cysts that you see are really follicles. Other pelvic structures, normal bowel gas pattern with normal gut peristalsis is noted. Always look at things which are which you see but which you don't really say. Bladder is normally distended with wall thickness of 4 millimeter. No mass lesion is seen in the bladder. Limitations. Now here, although we have mentioned the technique, it clearly mentions the limitations here. Maybe you can bring it before the findings. Probably I would put it after the technique, the limitations. Transvaginal ultrasound was suggested to the patient as more accurate way of determining whether or not there was an early pregnancy in the uterus or adnexa, but she refused to have this done. It appears that her understanding of English and of the procedure itself was limited. She also refused a TV examination on previous ultrasound. It is suggested that patient may be counseled and referred for a TV scan again if indicated. Right? So we have said that there are limitations to this exam. So this exam is clinically adequate as far as the transabdominal scan goes, but it is not a complete exam because we were not able to do a TV and what to do with that in future. Prior imaging, I note that the patient had positive urine pregnancy test 9 weeks ago and a positive and a previous ultrasound performed 4 weeks ago to establish dating of pregnancy, but no gestational sac was seen in the uterus at that time. Fine, we have compared that. Interpretation of these findings. Now here is what is your clinical interpretation of all that. Current timings may be compatible with all 3 things. If the patient had your positive pregnancy test 9 weeks ago, a gestational sac would usually be demonstrated in the uterus by now if the patient had a normal intrauterine pregnancy that was ongoing. So it has said 9 weeks ago it was positive. You see a gestational sac in uterus at 9 weeks of gestation. Okay, you start seeing that at 6 weeks. But if at 7 weeks you don't see the intrauterine gestation, then it is abnormal. So at 9 weeks we should be seeing if it was a normal ongoing pregnancy. It is noted that the previous ultrasound did not demonstrate an intrauterine pregnancy 5 weeks ago. At that time, it was 4 weeks. 4 weeks is too early. So that is okay. But at 9 weeks, we should be able to see the intrauterine gestation sac. A history of spotting and abdominal pain raises the possibility of previous complete miscarriage. Remember the word miscarriage, not an abortion. There are no sonographic findings that may suggest an ectopic pregnancy. It may be noted that a transabdominal ultrasound has low sensitivity in diagnosing an early ectopic pregnancy, but we are talking about 9 weeks. Okay, so here the interpretation is a lot more logical and a lot more, it has ruled out or differentiated between the 3 possibilities based on what ultrasound has been done. Okay, it is not an normal intrauterine gestation because we should be able to see that at 9 weeks. We could not see any ectopic, but early pregnancy, we cannot really show on transabdominal ultrasound, see the limitations. Okay, still a very remote possibility, but we are saying that today we did not find any evidence of that. Third possibility is spotting and abdominal pain, no intrauterine gestation, no ectopic. Most probably there is a previous complete miscarriage. What to do? Assay of beta HCG would help to distinguish between these possibilities. When beta HCG is this same thing which we said before, a close clinical follow-up is recommended until a definitive diagnosis is reached, because ectopic pregnancy has not been excluded. I would probably use a word completely excluded, or excluded with a high degree of confidence is fine as well. At this stage, patient may be managed as pregnancy of unknown origin at present. What has it done? It has classified this pregnancy according to the College of Gynecologic Gyneconologists. What is that called? RCOG. RCOG, is it? Royal College of Obstetrics and Gynecology. RCOG guidelines. And RCOG guideline classifies pregnancy of unknown origin, and then it has protocols, well-defined protocols, what to do after that. So you have given a definitive answer to the referrer. This is how you proceed. Okay. Communication. Due to urgent nature of the report, the patient's husband was briefed about the findings and advised to go straight back to you for further management. Findings were communicated to you by phone at 11:30 on this day. Dr. Paul, he is not only a Fransker, he is an MBBS as well. We just found out he's a consultant radiologist, so he's not a resident or a intern or anything like that, although he's Fransker. But you know, we have interns, Franskers working as interns as well. Two of my colleagues in Royal Brisbane and Women's Hospital have cleared their radiology board exams, but they are working as senior registrars. They are not consultant radiologists. And it gives the address so that I may be contacted if there is need. I would probably put my phone number there as well. Maybe not my mobile, but somewhere where I can be reached urgently if need be. Date of report and transcriptionist, who wrote it and who was the sonographer. You don't need to give their names because if there is a litigation and it goes to a lawyer, they can say, oh, there was this spelling mistake. Okay, whose was the transcriptionist? Who did this ultrasound? Was they a qualified person or not? So they can directly from the report say who the sonographer was. Once the patient is gone, even after 2, 3, 4 days, you completely forget about the patient. And if it comes back, then you are like, who did that? Who did that? Who did that? And if you have got 4 or 5 sonographers, it becomes very difficult to prove which of the people actually performed a scan. Okay, but if it is on the report, it is official, it is a legal document. And if you write something like that, this is distinction or high distinction level of reporting. Okay, so now you would understand how a report is written and what are the main requirements of writing those reports. And all of this is mentioned in the Royal Australian New Zealand College of Radiology's working document, okay, which you can basically see on here, which is probably a fourth, fifth one. Radiology written report guidelines, Ransker 2011 report, and then the short version as well, standard of practice, radiology report guideline project, that how the and why the Royal College came up and what effort was done to have these guidelines. Okay, fortunately or unfortunately, or whatever you call that, you get all these four kinds of reports from radiologists. So don't think that a radiologist is bad or good depending on these reports. It's basically just the way people have been trained, or the amount of work they have, the amount of time they have, and the amount of effort they have put in to writing the reports. And not all reports go to litigation, but when you are writing a report, one of the things in the back of your mind, that shouldn't be the main driving force, but in the back of the mind should be that this, whatever I'm going to write, can go to litigation, can be scrutinized, and every word will then be picked up and can be used against me. So that is why whenever you're writing, you make a habit and develop this habit of writing reports which are to a certain standard. Okay, so today's tutorial was basically about report writing, because your assessment is due pretty soon as well, which is on, when is that? Here, 7th of June, and today is 14th. So you have 3 more weeks to go before you have these sort of reports to be submitted. So I suppose that by the lectures, today's tutorial, and all the written material there, you will be able to write a good reports, not just to pass this assessment and to get good marks, but give an insight to you that what is lagging out there, how you can improve, and what is the logic behind doing all this exercise of writing reports. The argument against the Ransker and the biggest sort of objection to it was basically that if the radiologist started writing every report according to the guidelines, they won't be able to write maybe more than 20 reports a day out of 100 that they normally write. So it would be it cannot be implemented in full unless there is the workforce, the manpower issues are resolved, because radiologists are overworked and they just are time poor. I think I have argument against that because we are talking about duty of care, safety of patient, proper management of patients. So even if a radiologist can only write 1 report in a day, there should not be any compromise on the safety and the quality of service that you are providing. Any question, Michael and Kathleen?
So question, Amir, is it best to do present tense or past tense in report writing?
When you are
does a patient have or had an ovarian?
When you're describing something which has happened, for example, history of the patient, it's a past tense. The patient presented with, okay?
And in the body of the report, when so the uterus was or is antevirgin?
Is because you are right now looking at the images and interpreting them in the present thing.
So
but
always present tense.
Yeah, but when I'm comparing it with the previous report, I would say the previous ultrasound done 4 weeks before showed the uterus to be these centimeter, because that has already been done. That is in the past, and I'm comparing it with now. But what I'm interpreting right now is in the present tense. There are future tense as well sometimes used. A follow-up will be necessary, or a repeat scan, or the patient is recalled for a repeat scan in 3 weeks' time when he will come with a full bladder, or when she is expected to come with a full bladder. So the tenses are what you are doing right now. Even if the exam was done 2 days back, lots of radiologists, non-urgent things, they report 2 days or 3 days later, so but that is interpretation which is happening right now, so I will use present tense.
Cool.
Okay, anything else at all?
Amir, those 4 examples, I would have said report 3 was my favored report.
I would be I would agree with you a lot, because report 4 is rather a little bit too elaborate.
Yes.
But
so I read the long document where those examples came from, and they did surveys of the GPs and the radiologists.
Yeah.
And apparently report 3 was the preferred report out of all those groups. So report 3 is what I've based my style on. I thought report 4 was a bit too long-winded.
That's right. If it was a routine, normal ultrasound, and I would write a type 4 report, that would be too wordy, too lengthy, and unnecessary in a lot of senses. But look at the patient. It is an urgent patient coming for a clinical opinion where the referrer is totally dependent on what you are going to tell them, and the patient's management is critical. Okay, so in this very particular scenario, possibly report 4, which is a little bit more elaborate, is a lot, probably would be a bit better than type 3. But in a routine ultrasound, majority of cases, I would go for report 3. And so, your reporting depends on what is required and what you are trying to say there as well. But I agree with you that report 3 is concise. It has all the necessary information. It helps the referrer, but it does not go to the extent where report 4 has gone in this very particular case. In a routine case, probably report 3. Report 4, I would not give a distinction or higher distinction. I would say that, no, this report is too long and too wordy and too distracting to the referrer as well. Because if you write a lot of stuff, then they get confused that, okay, what is the radiologist trying to tell us? So you have to be precise and to the point, but contain all the information in there. So I agree with you, Michael. Yeah. All right. So again, I'm very sorry for the delay, but I came in at 7:10, so it's 8:10 now. We are one full hour. So if nothing else, we will call it a night. And in 2 weeks' time, we will have our last Zoom tutorial on 28th. So hopefully I would see more faces. And 28th, we will be talking about the end of that. Your both your assessment items would be in. One is due on 20th of May. The other one would be 7th of June. So you would be in between these two. So we will have a bit of discussion on at least your one assessment item in the next tutorial. And we will wrap up the communication and see how useful this unit has been to you as a sonographer or a clinician. Okay, well, you guys have a good night, and I'll see you in 2 weeks' time.
Thanks, Amir.
Yeah, bye.
Okay, good night.